Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer.
Fertility expert Dr. Amy Vazadeh.
And you have yet another success story
just launched by an East Bay fertility doctor.
Welcome to the Egg Whisperer Show. I have Tiffany Stankewicz on today's show talking to us about everything we all need to know about the EndomeTRIO Test and how it can help our fertility journeys. Welcome, Tiffany.
Thank you, Dr. Amy, for having me.
Of course. So I want to tell you guys about her background. It's pretty incredible. She has a bachelor's degree in animal bioscience from Pennsylvania State University. She's currently pursuing her PhD in genetics under the supervision of Dr. Garen Griffin at the University of Kent. Her research focuses on endometrial receptivity and genetics. She has over 10 years of clinical lab experience as a fully trained embryologist and is certified by the American Board of Bioanalysts, ABB, as a technical supervisor in both embryology and andrology. And in addition to clinical lab experience, she coordinated many aneuploidy and single gene cases as PGT director at a large IVF clinic in Philadelphia. She made the move to reproductive genetics in 2016 when she became a PGTA lab manager at Igenomix. Now her primary focus in the company pertains to endometrial tests, including ERA, EMA, and ALICE, and that's what we're going to talk about today. Tiffany, welcome. I'm so excited for you to tell us more about the EndomeTRIO test. Before we get into that, I would love for you to tell us more about how you got to where you are today and what got you interested in fertility medicine and this field, and specifically in endometrial receptivity and genetics.
So it was definitely a longer road. It wasn't a direct road to IVF or even endometrial health. So as most animal bioscience majors, I had intentions to go to veterinary school and practice small animal veterinarian medicine. But once I hit my junior year after working in a lot of veterinary clinics, it just decided that was not the route I was going to go. But during my time, I'd always had interest in animal reproduction and genetics. And I happened to, my first job outside of college was in an IVF clinic as an embryologist. And that's where it all came together. And actually, when you tell people, well, what's your background in animal bioscience? Patients will say, okay, well, don't put a cat or a dog in me. So that was a common joke. I don't know if they were joking, but I took it as a joke the whole time. But the funny thing is actually IVF started in cows. So we're not very far off base here. And a lot of, especially the quote unquote old school laboratory directors and embryologists, they have backgrounds in animal bioscience since they started in cattle IVF. So I'm not, again, too far off base with that. But really what solidified my love for this field is when I was introduced to PGTA. At the time it was called PGS, so we've gone through many acronym changes over the years. And just seeing genetics really come into play in the IVF field, I just completely fell in love. And that's where my passion for this field really ignited. And as my time working as a PGT coordinator, I was able to be a little bit more invested in patients, know their stories, and kind of be a part of their cycle. So I remember like after they're transferring a normal or euploid embryo, about 2 weeks later, I would stand at the blood analyzer machine waiting for their first beta to come off. And I would be ecstatic seeing a nice, high number. So that just, again, solidified it even more. So as that progressed and evolved, I really, really fell in love with genetics of this field. And I worked closely with Igenomix as a customer, and I just really believed in what they were doing and the people part of the company. And I really wanted to be a part of that. So I had the opportunity to make the switch over to Igenomix, and I've been with them. And through the evolution of it all, I just happened to fall into the endometrial side of it. And that just ignited things even further.
I like your use of the word ignite. I think I need to use that more in my day-to-day language. And Igenomix, Ignite, I mean, they're kind of similar. And you guys certainly have been trailblazers with so many things, including PGTA, and now with these tests. So I want to get into them a little bit more. And you mentioned, you're focused on endometrium and the receptivity there. So I'd love for you to discuss a little bit about the role of endometrial health and what it plays in conception?
Yeah, so for so long we focused on just the embryo. Is the embryo good morphology? Then once we introduce PGTA, okay, is the embryo chromosomally normal? But even when we had beautiful textbook quality, A grade embryos that were chromosomally normal, they wouldn't always implant. And when I was working in the IVF clinic, that was one of the frustrating parts when I would, again, wait at the blood machine, waiting for the first beta HCG to come off, and it was negative. And it's like, okay, well, that was the most beautiful embryo I've ever seen, and it's normal. What's happening? And even when I was in the clinic, I tried optimizing. This was back in 2014. I happened to see, or actually was attending a post-grad course with Dr. Carlos Simon, who is the chief scientific officer at Igenomix and the powerhouse behind the endometrial receptivity analysis test. He's devoted his life practically into understanding the endometrium. And at that point, I thought, okay, maybe we need to start looking at the other side of the equation, because not only do we need a healthy embryo, but we also need a healthy receptive endometrium to make this process work. And the process I'm referring to is implantation. So we know that endometrium is important and the uterus is important for pregnancy, but also for the initiation of it, the implantation. And again, we can't have implantation or, again, a subsequent pregnancy without both players being healthy.
And then what is chronic endometritis?
So chronic endometritis is a persistent inflammation of the endometrium. So the endometrium is a lining of the inner lining of the uterus. And again, that's where the embryo will implant, and that's where the pregnancy will persist. But when we have chronic endometritis, that lining is inflamed, and usually because of bacterial pathogens. Now, what's tricky with endometritis is that it is usually asymptomatic, so we don't typically detect it.
And then you guys came up with ERA, that test, and that's been around. I mean, I've been doing it since 2013, believe it or not. And then with the addition of Emma and Alice, and I know you're going to talk to us more about that, now we have these 3 tests. So can you tell us a little bit more about all 3?
Sure. So I think you were probably one of the earliest users here in the US. So the ERA test has been around since about 2011, 2012. And I guess we'll start with the ERA test because the ERA test has been around the longest. But basically what we're doing, we're trying to understand when a patient's endometrium is going to be receptive for an embryo to implant. The tricky thing here is that before we really started looking deeper into endometrial receptivity, we had just assumed, okay, every woman has a receptive endometrium at this time, usually 5 days after progesterone exposure, about a week after, LH surge or HCG trigger, but we know that's not true. We know that some women might have a window of implantation that opens a little bit sooner. Maybe it opens a little bit later, or it's a very short window of implantation. So the ERA test helps us understand where a woman's window of implantation is so we can plan the transfer accordingly. Now, what we do to find this, we look at, it's a genetic test. So there have been tests previously where we're looking at, say, histology, but those had shown not to be really reliable, or it was hard to clinically apply those tests. It's like, okay, well, if the endometrium is out of phase, now what? We didn't have any clinical action. So with the ERA test, we take a piece of endometrial tissue at a certain time in the cycle, and then we apply this genetic test. So we use something called next generation sequencing. So if you've heard of this, it's the same technology used for PGTA. And we're looking at gene expression. So which genes are turned on and which genes are turned off. So we know that there's certain genes that are going to be turned on and certain genes that are going to be turned off during the receptive phase. And that's how we're able to say, okay, you need 12 hours more progesterone before you transfer, or you need 24 hours more. And, obviously we release the report to physicians, and then you'll undergo a transfer based upon the result and recommendation.
And then how do all 3 work together?
So Emma and Alice have just been released as far as being offered in the US. I would say been about 3 months now. And what these tests can do together is that you would run ERA for receptivity, and then Emma and Alice look at the microbiome, or the endometrial health as far as what bacterial pathogens are present. So we bring both of those together because we know when we optimize receptivity and we optimize the endometrial microbiome, we see much better clinical outcome as far as pregnancy rate, implantation rate, and lower miscarriage rates.
Can you tell us a little bit more about each individual test, like the Emma test, for example? How is it done?
So Emma is a full comprehensive view of the endometrial microbiome. So what we're looking at with Emma are going to be 4 lactobacillus species. So lactobacillus is the good bacteria. So you may have heard of this in the gut where, we want to drink a lot of yogurt drinks or our probiotics to help our gut health. Those are consisting of lactobacillus. So just how lactobacillus is a good bacteria in the gut, it's also the good bacteria in the endometrium. So we want lots of that there. So that's the first thing we screen with Emma. The second thing, we look at 11 bacterial pathogens of the reproductive tract. So pathogens being, the bacteria that we don't want present there that may be related to difficulties with, say, implantation or actually maintaining the pregnancy, or maybe pertaining to obstetric complications. And then lastly, we look at 9 additional pathogens that are specifically related to chronic meningitis itself. So to kind of summarize that, we look at the 4 good species of lactobacillus, and then 20 total bacterial pathogens, either related to chronic meningitis or not, but either way, that shouldn't be there.
And if the microbiome is out of balance, how do you treat it?
When the microbiome is out of balance, we have to look to see, okay, what is causing this to be out of balance? Is it just simply, okay, maybe there's no pathogens present, but also there's not a lot of lactobacillus there. Remember, lactobacillus is a good bacteria that we need, that's been associated with improved clinical outcomes following IVF. So if that's the case, we consider this a dysbiosis. In those cases, we can give vaginal probiotics in order to replenish the lactobacillus species in the endometrium. Now, in cases where there are pathogenic bacteria present, so for example, whether they're related to chronic meningitis or not, we can give a specific antibiotic to target those bacteria present in your sample. So right now, chronic meningitis, we get, with previous methods, we might show signs of inflammation, but we don't actually know which bacteria is causing that infection in that patient. So in most cases, we'll give broad spectrum antibiotics in hopes of curing them. The problem is that if we're not targeting the specific bacteria that's actually there causing the disease, that bacteria can actually proliferate more because there's less competition from other bacteria that may be there. And at the same time, we could be affecting the lactobacillus. So we might take a pretty bad situation and make it worse. But now actually when we see which bacterial DNA are present, we could say, okay, well, this pathogen is going to be treated if we give this particular antibiotic. So the physician will give that particular antibiotic, target that pathogen, we're rid of that, and then we can, again, replenish with the vaginal probiotics to get that lactobacillus back up.
And does the probiotic actually have to be administered vaginally, or can it be oral?
So we do always recommend vaginal administration because we want to replenish the lactobacillus in the endometrium. So the most direct route is going to be through vaginal administration. So when we take oral, obviously it's digested. We may not get any of the benefits in the endometrium.
And then if you are in a sexually intimate relationship and you are positive for a bacteria, should you have your partner also treated?
That's a really good question. So we at Igenomix do not give direct recommendations for that. So it's something that can be done on a case-to-case with the physician themselves.
And if someone has a positive for the Alice test, for example, or even for Emma, and are people actually going back and doing repeat biopsies to see if the pathogen has been treated or there's lactobacillus present before they do transfer?
So we don't give a direct recommendation to rebiopsy ourselves. However, I know a lot of physicians are opting to rebiopsy because they want to ensure that the treatment they apply is going to be successful. Sometimes there might be a combination of bacteria present. It may not just be one single bacterium. So that could be a little bit trickier to treat. So I always use the prime example. There's a bacteria called Gardnerella. This bacteria is extremely difficult to treat sometimes because it has a special ability to create a film around it, making it difficult for the antibiotics to kind of penetrate. So if that bacteria is present along with, say, another bacteria such as Streptococcus, that's the same bacteria that causes strep throat, it might be a little bit difficult to treat both of them at once. I'm not saying it's impossible, but sometimes, depending on the severity, it can be. So by performing that second biopsy, we can make sure, yes, all the bacteria is gone, and look, the lactobacillus is restored, and this is an optimal microbiome for implantation.
And totally separate thought that I'm having here is there a certain profile that you see perhaps in people who might be at high risk of having endometriosis or adenomyosis? Have you guys noticed any patterns like that?
We have not seen that yet. I'm sure that's something that we're looking at. So we do collect a lot of this information on clinical samples, and we're always further investigating what other IVF indications could be linked to these tests.
And have you noticed that EndomeTRIO helps with patients who have recurrent pregnancy loss as well?
So chronic endometritis itself has been linked with RPL or recurrent pregnancy loss. We know that about the prevalence rate can be up to 60% in that particular population. So the benefits for patients with RPL could be clear because, again, if chronic endometritis has such a high prevalence rate in this population, these patients can benefit by screening appropriately for it.
So if a patient, because I would say so many of my patients, for example, have done the ERA test, and if, let's say, they are now considering doing Emma and Alice, is there a way for them not to have to undergo another biopsy? Can they just add on the test, or do they have to go back and get another biopsy done?
So this is a really great point that you brought up because the microbiome shifts over time. And we know it can shift things such as antibiotic use, sexual intercourse, hormones, hygiene, a whole array of things that are sometimes out of our control. So it's really important to take the biopsy in the month prior to the anticipated transfer. We really want to understand the microbiome at that time because we want to help ensure reproducibilities of that finding and the endometrial microbiome status that we encounter. So if we were to say run a sample that was biopsied last September and now we're, I don't know how many months, maybe 9-10 months later, it's not going to be accurate for the status how it exists today. So it's
and then let's say for that patient who, let's say, did the ERA test back in September, when in her cycle could she do the Emma and Alice? Could she do it, let's say, when she does her egg, let's say she's doing another egg retrieval before she transfers to bank more embryos? Could she just do it during the egg retrieval? So she's already asleep, she doesn't have to have an extra appointment, and then she won't have pain?
Yeah, so we wouldn't recommend it during then. We do always recommend in the secretory phase. So the secretory phase is going to be after ovulation. And the reason why is because we want to, one, understand the endometrium that the embryo will encounter implantation. So if we take earlier than that, that's really not the environment that the embryo will encounter. The other thing, we know that the endometrium, as far as the microbiome, is most stable in the secretory phase. And then the third reason, which relates to reason number 2, is that in the proliferative phase, especially close to menses, the presence of blood can lead to a temporary dysbiosis. So that blood can cause the lactobacillus to decrease and maybe other bacteria to flourish. So for all those reasons, we say in the secretory phase. So specifically for our protocol, it's going to be a natural cycle, day 15 to 25, for women who have normal cycles between 26 to 32 days. And then if a woman does not have regular cycles, we recommend in a hormone replacement therapy cycle or HRT cycle on P+5. The other tricky thing is that we need to avoid antibiotics at least 7 days before the biopsy, during the procedure itself, and after the procedure until the results are obtained, because we don't want to mask something that's there. We want to understand, okay, how does that endometrium exist without any influence so we can apply the proper antibiotics and probiotic treatment.
So same thing with probiotics. So they shouldn't use probiotics vaginally before the biopsy as well.
Not directly before. I don't know if that's maybe their normal regime is to use vaginal probiotics on the regular, but I wouldn't add anything right before that could possibly influence, because we want to see how this exists so we can treat accordingly.
With a lot of new tests that come out, some doctors are hesitant to use them because they don't feel like there's been enough quote unquote research. Where can patients learn more about all the research studies that you guys have published about these tests?
Yeah, so we have a lot of our studies found on our Igenomix website itself. Of course, I always recommend PubMed, which I know is a great resource, especially if you're already in the science field. I'm sure you're very familiar with it.
Patients can go to the Igenomix website to read the research articles that potentially could help them talk to their doctors about the test, because sometimes doctors don't want to do tests that are brand new. And I tell my patients it can take doctors sometimes 5 years to even start doing a test that's come out because they want to wait for the research. But when you're a fertility patient, you don't necessarily have 5 years to wait. So you guys go to the Igenomix website to read more, and you can definitely ask your doctor to do it for you, especially if you're already doing the ERA test. But at the same time, if you have a doctor that's not doing it, is there a place on your website where people can go to find a doctor that will do the test?
So we don't have that available at this time, although it's something that perhaps in the future we can somehow add. But one thing I do want to mention is that we do have patient webinars available, usually monthly, and they'll cover an array of topics. So, for example, in May, I just did a patient webinar about ERA, and it's a really great resource for patients because I'll give about a 20-minute talk about the science itself and the clinical utility of the test, and then we open up for a Q&A session. And if there's anything specific that we're not able to answer that might be, pertains to your cycle protocol exactly or your results, we always follow up with your physician to make sure that we can provide all the information necessary so they can provide you with the answers you need. So I would keep your eyes out for that. I'm sure we're going to be having an Emma and Alice patient webinar in the next few months. As I said, these tests have just been introduced to the US market in February, so they're still quite new. But again, we want to offer as many resources as we can. I know too, we have some videos on YouTube that will explain our tests further.
And general OBGYNs could even do the test as well, right? I mean, it doesn't necessarily have to be just for the IVF patient who's doing the ERA test. A general OBGYN could potentially take advantage of this test, especially for the patients who are having recurrent pregnancy loss.
Yeah, you're absolutely right. For Emma and Alice, specifically, this could be performed by OBGYN. And like I said, it could be applicable for any woman wishing to conceive, just to understand, okay, what is the endometrial microbiome that I currently have that my embryo will encounter implantation. Now, the ERA test wouldn't be applicable for an OBGYN since it has to occur in a frozen embryo transfer cycle, but Emma and Alice for sure.
Tiffany, is there anything else you'd like to add today?
I think the one thing is that we didn't discuss is the actual treatment itself. So as I said, since the microbiome can shift over time, we really want to take the biopsy in the month prior to transfer. So you might ask yourself, okay, well, what if we have, say, pathogens present and a low lactobacillus? How are we going to have time to treat? Fortunately, the treatments are quite minimal as far as duration. So antibiotic treatment might range anywhere from 1 day to 7 days. And then probiotics is about a week long. So you could easily biopsy, treat accordingly once the results are received, and then transfer in that next cycle. So within 2 months, we can get the testing and get you to transfer. So it's pretty patient friendly.
That's actually pretty helpful. So the probiotics, they should only take it for 1 week?
Yeah, you always want to follow the instructions on the commercial product itself. So I know one commercial product that we have approved. That one I think is a 15-day regimen. However, we do have another product that has been approved by Igenomix, and that's through a fertility pharmacy. That regimen is, I think, 6 or 7 days. So it depends on what your treatment schedule is. My recommendation might be, if you're trying to get to transfer and say you're in HRT cycle, because there's certain times when the probiotics can be given. For example, if you're giving vaginal progesterone, you don't want to give vaginal probiotics at the same time. It could be a little bit irritating. So you want to make sure you complete that regimen before starting your vaginal probiotics. So maybe choosing the shorter round is going to be a little bit more helpful for your actual treatment schedule.
What I think could also happen is people learn about this test and then they say to themselves, well, I'm just going to take a probiotic anyways. And is there any such thing as taking too much, like taking it too long?
I mean, I think with anything, taking too much of anything is not going to be a good thing. Even if you drink too much water, I mean, that's not good. But in any case, giving a vaginal probiotic or taking a vaginal probiotic may not be helping a situation that might already exist, especially if there's bacterial pathogens. It doesn't matter how many vaginal probiotics you take, those bacterial pathogens can still persist. And those are the things that are causing chronic endometritis and have those links to, poor reproductive outcomes or obstetric complications. So we really need to assess before treating, so we can treat appropriately.
Well, Tiffany, thank you so much for coming on and teaching us about the EndomeTRIO test. I really appreciate your time, your expertise, and all your knowledge. So I hope you'll come back on again, and hopefully you'll introduce a non-invasive way to check this, to detect these things. I can tell you that if I could do this test without a biopsy, that would be amazing.
Yeah, hopefully that will be down the pipeline soon. So thank you for having me. I really enjoyed being here today.
Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer.
Fertility expert Dr. Amy Abazadeh.
And you have yet another success story.
Just launched by an East Bay fertility doctor.